This is Digital Pathology Today. Now, here's your host, Dr. Joseph Anderson.
What is the current state of the practice in digital pathology as we enter 2022? Where are we in terms of integrated workflows, predictive and prognostic algorithms based off of H&E morphology? And what about incorporating artificial intelligence into workflows or diagnostic assist devices? Welcome to Digital Pathology Today. I'm Joe Anderson. Our guest is Dr. Michael Feldman, professor of Pathology and Laboratory Medicine at the University of Pennsylvania, as well as vice chair for clinical services and director of the Office of Pathology Informatics. We're going to be talking about all these things. And in addition, perhaps perspective from an academic setting on digital pathology. Where are our digital fellows, these artificial intelligence-enabled machines that will organize, prepare, preview, maybe even diagnose cases, prepare the report, everything except for signing them out? Is that going to be our reality? What does image analysis and computational algorithms mean for the diagnostic acumen of trainees or the next generation of pathologists? Dr. Michael Feldman from University of Pennsylvania, welcome to the podcast.
Thanks a lot, Joe. Nice to be here.
We're excited to hear from you. I want to first start off with the state of the practice. Where are we in mid-2021? We're a year after this global pandemic, which saw kind of an acceleration of digital pathology, particularly with pathologists being able to sign out cases remotely, and everyone is very optimistic. But I just want to check in and see, where are we in terms of practical solutions that we can implement or that we have implemented in actual practice? So I think a big topic is integrated workflows. So first of all, what does that mean? What are the steps it takes to implement that, and where are we right now?
I think we're at the very, very beginning phases in the United States of seeing adoption of digital pathology. It's expensive, right? And so putting together the business case, the use case, to begin putting scanners in, to begin integrating that into our practice. We're taking a phased approach at Penn. The first phase is to begin to get the team used to modern scanners, what the image quality looks like. Everybody has seen digital slides, but those are first, second, third generation devices, and the newer scanners are quite a bit better quality. And then starting to think about where's the value after you get a digital slide. One of the things we're thinking is, with some of the early AI software coming out, not FDA cleared yet, but I have no doubt that they'll be in front of the FDA in fairly short order. They really present the opportunity. I like to use this term digital fellows, where each software application becomes an express digital fellow that does work for the pathologist. It'll screen my prostate biopsies. It'll find all the cancers. It'll triage the cases. And so, those present value. Those present value because we're a growing health system at Penn. We're hiring more GU surgeons. There's more prostate biopsies, more patients coming in. And so if I can make my pathologist more efficient, because the digital fellow is working at 2 a.m. in the morning, and when they come in after their coffee, they already have everything previewed with a digital fellow that's 98, 99% accurate. We see value in that in terms of getting people home a little bit earlier, preventing misdiagnoses, getting a consistency and a uniformity across people and practitioners at multiple sites, so that what I call a 3+3 or a 3+4 is the same thing at one of our other 6 hospitals. So we see real value in that. But what we're not rushing to is to do a complete digital install and convert all of our glass to digital. I think there's still challenges to that. It's very expensive, and the business case is hard to articulate. We're proceeding into this, pairing up software applications, AI, machine learning, that do things for us. And those are the cases that'll get scanned, and we'll have the algorithms run on them to do work for us, make us better.
Okay. Yeah, I think it is very daunting, right? Just coming up with an end-to-end solution or going fully digital, I think is very daunting. So I think an approach a lot of groups are taking is, how can we identify a place where it makes sense to jump in?
Yep.
And this idea of the business case, I think, is kind of coming to the forefront now. The DPA came out with a white paper recently kind of addressing that question. What is the business case for digital pathology? Because I think it's, in some form, it's been with us for about 20 years or so.
Right.
And we kind of know what the secondary benefits are. It's fun. Oh, gee, wouldn't it be great to look at a computer monitor than a microscope? It's going to be nice to share my cases with people all over the world. They're going to give me their expert input. I don't have to schlep glass slides everywhere.
Mm-hmm.
But how does that translate into dollars and cents? What efficiencies can we gain? How can we make things cost effective? And I guess the bigger question is it going to make sense to invest in these systems? And I think up until now, it has, it's been a kind of a lot of hand waving and glib talk.
I mean, one of the things we're looking to do, so CMS and getting billing codes for digital is something that the DPA is going to, DPA, CAP, so on and so forth. They're going to lead the charge on this. But, that's an uphill battle, and it's a multi-year process at its best. I think there are other opportunities to commoditize the use of digital pathology. And, once we're up and running and we've got the AI in place, I think there are interesting opportunities to go to the insurance players and articulate a path that says, yeah, you send me all your prostate cases and we'll read them this way. And we've got a better mousetrap. And so maybe not commoditizing it by getting more per RVU, but just getting more RVUs because we can do more work when the AI is actually working. And the real value to the health system, I jokingly say I'm going to put up a big billboard on the highway that says, your prostate is worth Penn medicine. I'm half joking, half real is, if we have a better mousetrap that provides a better quality, prevents misses, gets more uniformity, why wouldn't you have your material seen at Penn when we become the one-stop shop, in our region? So, I think there are different ways of commoditizing it while the RVU story and CMS reimbursement, does its thing.
That is interesting. As an aside, I have seen billboards on buses going by, kind of advertising for the competing business. I know Philadelphia is a very competitive market between Penn, Fox Chase, Temple, Jefferson, and so forth. So I think really, how do we add value? What is going to be the advantage of coming to Penn, or what's going to be the advantage of having your specimens reviewed by our pathology group? And so just sort of curiosity. So if we go the route of adopting new CPT codes, moving away from 88305, 88423 or what have you, with the expectation that we're able to be more high throughput, we get more efficiencies, maybe the quality's better because we have these digital fellows reviewing our cases, is reimbursement going to be higher or is it going to be lower per case?
To get more out of CMS is sort of an act of God, right? I mean, I think that's going to be hard.
I mean, that's kind of the depressing thing about medicine or, economics in general is the pie always gets split up into more pieces, right? And so you'd think, well, with all these great new innovations, it's somehow going to be more, more worthwhile for us to do. But is that going to be the case?
I'm not looking there for the business case. I just think that's, trying to get blood out of the stone. Maybe somebody will get lucky and we'll get a little bit more out. Perfectly happy to write letters and support them to do that. But I think the better value is what I can bring to the health system to drive more business to Penn Medicine. I mean, Penn Medicine makes its dollars on providing complete care, total care. And so if we have a better mousetrap and we can do the diagnostics better and they can grow their prostate health business, I think that's a more compelling case. And, then I can negotiate with people that I know to say, this is how much it cost. Some of that new business was brought in through the diagnostics. And so let's make sure we cover the cost of the business.
Yeah. That is compelling. Now you said you envision these AI fellows running around or digital fellows, and they're not 98% accurate. That sounds better than the human being fellows.
To be discovered, right? I mean, that's the marketing hype. It's like bringing in a new chemistry analyzer. Does it really do what it says? and so you have to be rigorous in how you evaluate this, as rigorous as we are in laboratory medicine. It's not a toy, and you've got to put it through the accuracy and the precision and the reproducibility, and you got to test everything that's in the IFU, the intention for use, as these things go through their clearance process. I need on Monday when I scan a slide, and on Friday I better get the same damn result, right? I mean, you got to go through the the machinations to really prove to yourself that these algorithms work.
Yeah, when all is said and done, accurate, precise, and reproducible. No question about that.
It goes back to basics, right?
Yeah, exactly. Can't get away from the basics, the blocking and tackling, as they say. So, when we incorporate AI, I think there's several different types of workflows that you're kind of alluding to. One would be previewing the cases or maybe triaging the cases, so getting the right case
Primary
to the
screening.
right pathologist. Yeah, screening. And then another aspect, would be a more narrow application, say in previewing a very specific thing like prostate biopsies, which is probably the most narrow application I can think of because we're generally looking for the same thing every time, right? Is there cancer here? Yes or no?
Yep.
And maybe if there is cancer, what's the Gleason grade? But that's, presumably less important than finding the specific suspicious area.
I would argue it's actually both. I want my first prostate AI to find the cancers. I want it to Gleason grade it and score it and grade group it. I want it to find perineural and lymphovascular invasion. I want it to flag if it sees extraprostatic extension. I want this to be a good fellow. I want not a super thin AI. I want an AI that has a little more oomph to it. And then I want it to write the report so that when I'm looking at the slide and looking at the report, I can say, yep, you got it right. I'm going to modify this. And then copy and paste into my computer system and verify the case.
Okay, so that is literally a fellow, right? He's doing everything, start to
literally
finish.
A fellow. I'm not kidding when I use the metaphor digital fellow.
Okay, and so realistically, how far away are we from this reality?
So that software is up and running in multiple places outside the U.S. I think the company IBEX is going to be submitting to the FDA to get this approved in the United States.
Mm-hmm. Yeah. So IBEX, we've had them on the podcast. They have deployments throughout the world. They need to overcome this FDA barrier, so to speak. But yeah, I think we're all excited about that. And so then actually implementing it in your institution, right? So FDA approval or FDA clearance is nice, but then what's it going to take? It's not going to work out of the box, is it, right? You have to go through all this. You need to validate it or verify that it works in your institution.
Yep, absolutely. We're going to manage our digital pathology environment using our radiology packs. So we have the Sectra packs at Penn, and as part of our first phase of digital pathology is we're enabling the digital path side of Sectra. And Sectra and IBEX are now working on moving the images out of Sectra into either Amazon or Azure, having the IBEX run and then bring the data back into the Sectra packs. So that's an active process right now.
Okay. And so you mentioned the PACS system. So I think it's interesting, as pathology goes further on this digital journey, and radiology has been digital for some time, but do you foresee kind of a fusion of the two specialties or they're after all both image-based specialties. And then, once pathology images become data, perhaps even more so, but there's been silos in medicine, or I guess that's human nature. There's silos everywhere, but particularly in medicine.
There's a financial incentive to have silos, right? We each get paid for our RVUs. And so why keep them together? You can separate them because I'm getting paid for my RVU, radiology is getting paid for its RVU. But, when the RVUs eventually go away, if they do, and we get paid for taking care of the patient with a single lump sum payment, it makes it more compelling to start talking about, did I really need those 3 radiology studies, or should I have gone right to the biopsy after the first one? Then you're talking about, it's much easier to see a convergence. So having the digital pathology inside the radiology makes sense because, so many of our modalities in pathology require us to look at the radiology. I need to know, why did they biopsy this organ? And a lot of the information on lungs, breast, not as much prostate, but maybe a little, certainly bone and soft tissue, liver, pancreas. What was the lesion they were going after? What was the gross? And so being able to juxtapose between those two makes a lot of sense. And frankly, having a PACS, you got a fully HIPAA compliant, secure environment with a team that's running and an enterprise imaging operation with large data storage. It's all sitting there. And what I need to do is teach them a little bit about pathology. We need to add some storage capacity to it, but I don't have to recreate the wheel. So from the enterprise standpoint, it's much more effective financially to leverage that.
So these silos you think are at least now largely driven by RVUs or, fee for service type billing, rather than a value-based billing.
I think that's part of it.
But then it's technologically as the specialties become more intertwined, do you think we're going to see a more unified approach in terms of diagnostics and reporting, or maybe even, having pathologists interpret radiology images and utilizing things like specimen mammograms and so forth?
Well, we do that already, but we don't bill for it. When we sign out breast biopsies, we're looking at the radiologic images to make sure what I'm seeing microscopically correlates with what the mammographers were seeing. And when there isn't a good correlation, there's a phone call, right? Then you're talking to the mammographer and you're saying, okay, this is what I'm seeing. What did you see? And you're wrestling with, is that a good correlation or not? Sometimes it's not, and we just miss the lesion. Other times, they're comfortable when we describe what we're seeing, and then other times they say, no, but that person will come back. I'll just bring them back in 3 months or 6 months. So I'm comfortable watching it a little bit more closely. Yeah. I think we do that, but we do it in concert. I mean, I'm not a trained radiologist. I'm never going to be, and I think there's a domain expertise they bring to the table. There's a domain expertise we bring to the table. Moving digital might allow us to practice in the same space. So the reading room in breast might be a reading room that has a bunch of mammographers and then 1 or 2 pathologists reading the cases as they come off the scanners. So instead of having to go chase somebody, I can just turn around and say, look at Miss Smith, and this is what I'm seeing. Does it fit? And so I think there's some opportunities there.
Yeah. Okay. That does sound like an intriguing future. And what about silos even within pathology? I think the silos between AP and CP.
We don't have those. What are you talking about?
Even molecular and anatomic pathology, which you think would be a good marriage, right? Are we hindered by silos there? And, are we going to be moving to a more integrated reporting format, do you see?
I think we will. We're starting to wrestle with how to create an integrated report. We're trying to piece it together from our disparate systems. It's certainly not easy, but I think there are opportunities to do that. I think within the PACS, there are some interesting opportunities as well, because, you want to go from the radiographic lesion to the tissue diagnosis, and from the tissue diagnosis to the genomics. Having the radiology and the pathology together, having an application that can run on the biopsy that says, I found all your tumor and it's 13.5% tumor nuclei, that then feeds over to the genomic information system. Yeah, I think that's coming. So I definitely see that. It'd be really cool if my PACS could also handle the genomics information. Wouldn't that be cool? So, maybe.
Yeah, that would. I mean, I think driving towards a grand unified approach, so to speak, breaking down the silos or simplifying things.
Yeah, so maybe the genome information systems can communicate, through the PACS, through APIs. The nice thing about the PACS systems is they're a little bit more open and accessible than the LISs. Some of the older LISs don't have web service architectures, and the Sectra PACS is a tad more interoperable and interchangeable than some of the older LISs. So there's a little bit more you can do.
Okay. Now let's talk about quality control, which is a very important topic in pathology. And I think probably is going to take more of a center stage, as we move towards a digital workflow.
Absolutely.
So I think for several reasons. So one is, these digital fellows that you have running around, could you think of them under the guise of quality control?
So we actually have a grant where we built a quality control application to monitor the output of the histology lab. And so, as humans, we read through some pretty messy slides sometimes, and we don't ask for the recut until it gets really ugly. But eventually it gets beyond what even we're comfortable reading. But the AI application, if there's bubbles on the slide, if there are folds in the tissue, and it can't read that worth a hill of beans. We developed an application. I do a lot of this work with Anant Matabushi and his team, and we actually got an R01 to fund this that we call HistoQC. It's actually out there on GitHub. You can download it and enhance it and add more code to it. But it's basically, as the H&Es come off the scanners, this software is running over the slides and looking for areas that are out of focus, poorly stained, where the glass cracked, there are air bubbles underneath the slide. There's folds in the tissues and whatnot, and it's highlighting those. And then you can do one of two things. You can output that information and give the lab feedback that says, okay, of the 10,000 slides you made today, here's the defects, and you can sort them by, okay, these different pre-analytic changes. You could then link it up to the LIS that says, okay, who cut those, and give dense feedback to the manager to say, okay, this tech's having a bad day, go talk to him. And then the other thing it can do is it can obscure areas that the AI shouldn't look at because we know there's a defect in that slide. Or it could simply say, you have too many defects in that slide. Don't even bother scanning it. Just recut the darn thing. And, recut it at whatever, 2 a.m. and get it out to Feldman before he gets there. So.
Yeah. So we had Anant Matabushi on the podcast, and it's fascinating because I think, going digital, I think really is going to highlight the importance of high quality H&E stains. Right, because in the old days, like you said, it was kind of a badge of honor to fight through the bad staining and the bubbles and what have you. Or you'd say, well, it's a poor carpenter that blames his tools, right? So you kind of, and another aspect is that we weren't really looking at color, right? Like you're admonished, like, oh, don't pay attention to the color. We're just looking at the size and shape of the nucleus, what's making glands, and this, that, and the other. But color is just an artifact. Right. You're not making the diagnosis because it's purple.
Right.
And, but now as we move from human beings looking at these things to digital fellows looking at these things, I have a feeling the digital fellows are going to be much more interested in what the color is, what the qualities of the color are, what the contrast is, because in some sense, that's really all we have is the color.
That's right. Yeah. We wrote a paper a number of years back that looked at the different features that you can extract, and some of the features are invariant to color, and other algorithms are extremely sensitive to color, to the scanner, between two scanners. They produce a different color space. They produce a different pixel size. So yeah, these pre-analytics are really, really important to pay attention to. And, as you go shopping for AI, one of the things you really need to know is, how the hell did they train this thing? Did they really go about and capture all of the biologic variation in the disease? So did they see enough cases? And did they test this in enough laboratories with enough H&E variation, enough microtomy variation, enough scanner variation to capture all of that, so that when you bring it into your lab, it's actually going to work? I think that's to be seen. I think some companies do it better than others. And I think that's one of the things the FDA is going to have to regulate a little bit, is in the intention for use. They're going to have some performance metrics that can give us, the customers, the confidence that these things have been designed and tested in a rigorous method.
Yeah. So now with these digital fellows specifically, do you think of them in terms of quality control? That is, are they checking your work? Are they checking the work of a human being? Or do you see it more as a primary read, and then you, the human being, are checking the work of the digital fellow?
So I think there are two models. There's primary read and secondary read fellows. I like the primary read because if the performance is high enough, it's real time and you're not reworking. The secondary, where you make a diagnosis and then the system says, okay, did you get it right? It's a rework process, and that's not going to make me more efficient. So I think the primary read is going to give us more bang for the buck. Although I had an interesting conversation with the folks from Google. They've got that enhanced microscopy where they project the AI into the oculars. that was interesting. Not giving you a diagnosis, but it's calling your attention to stuff as you look for things.
I see. Hey, look over here.
Yeah. You're pushing the glass and it's firing off red highlights to say, look over here.
Yeah. So what does this mean for human being trainees?
No, that's a great question.
Are we going to lose our acumen if we have digital fellows telling us where to look or what the answer is already? I mean, how are we going to train people when we have all these great tools out there in the basics?
I love that question. So I'll tell you a story and you'll immediately understand it because you're older like me. So I used to be really good at reading maps. I used to get from point A to point B. I had a Rand McNally paper atlas in the back of my car, and I could find my way pretty much anywhere with that thing. But then GPS came out, and the Rand McNally went to the trunk, and the GPS was in the front seat. And I found myself in a city that I wasn't familiar with one day, and I couldn't get a GPS signal. And I was like, wow, how do I get out of here?
Right.
So your point of how do you, when you have these tools that are doing so much work for you, parts of your brain can atrophy. And so how do we train people? How do we maintain their skills? And how do we teach them the new skills of becoming savvy purveyors of this new equipment? I don't have an answer. We're wrestling with it intellectually. We haven't implemented anything yet. But I do think there are some opportunities where the digital pathology can create, I'm spitballing it here, so I'll just throw out some ideas that are completely unbaked, but the ability to create collections of material that can be beamed to the trainee on a as needed basis, right? And so normally the trainee learns by an apprentice style where they sit at the microscope with you, their day-to-day cases come to them, and that seems to work. But in a digital world, you don't have to wait for the case to come to you. It's sitting on spinning disks, and you can create collections, if you will. You work through these 500 prostates, and you will become really good at something. I can push them to you at home, at work. You can then spin up multi-headed microscopes and work with other trainees. You can then loop an attending in for virtual discussions. I think there's a way of, they talk about the flipped classroom. I'm wondering if there's an opportunity to flip the resident training program a little bit.
Yeah, that's interesting. I think there's always, with great change comes great opportunity. So I think it's maybe just a matter of finding the sweet spot or finding what that is.
Yeah. I think we need to rethink it a little bit. Just doing the apprentice style, you could easily get lazy and let the digital fellow read it, and then you come to the attending and go, look, it's a 3+4, as opposed to really wrestling with it with the digital fellow turned off.
Yeah.
I think it's going to be interesting.
I mean, maybe that's an answer. Turn off the digital fellow, right?
Yeah.
We need to somehow find a way to keep the skills sharp just on the basics, right? The old-fashioned learning way.
The nice thing is in a PACS, we could code that, right? And so if we wanted to do that, we could have the fellow scored already. And then when the resident logs in, we hide those scores and we make the resident diagnose it. And then at the end, when they say, okay, I'm done, move on to the next case, then the fellow comes up and says, okay, this is what I got. This is what you got. Compare. And then you can go to the attending and do the final arbitration. Maybe that's the workflow. I don't know. I think we have to try a few things.
Yeah, absolutely. It's going to be interesting. Well, Dr. Michael Feldman from University of Pennsylvania, thank you so much for being with us. Before we wrap up, maybe just tell us a little bit about yourself, your experiences in pathology, and how you came to be interested in digital path.
It's a total accident. I've spent my entire career at Penn. My initial intent was to go off and do tenure track, R01 research. I did a postdoc, and I got a taste of the grant world, and it was tough. It was an eye-opening experience. And so I came back and said, I don't know if I want to do a pure tenure track. Maybe there's a way of carving out a translational opportunity here. And I spent a bunch of time talking with one of my mentors, John Tomaszewski. We spent a fair amount of time, and he said, there's this thing coming where we're going to be getting more into data. And this digital stuff is going to not today, but, over the next 20 years, 30 years, this is going to become big. And so I started reading about it, and I was like, that's interesting. There's a whole aspect of practice that's digital, whether it's data analytics or digital pathology. I saw the writing on the wall that if I could combine my interest in technology with the practice of pathology, I could create something. So they gave me the latitude at Penn to play. It's about the first or second year into my faculty position. I met Anant. Anant was a grad student, a postdoc at Penn, and we were working on a project together. I love telling this story. He and I still get a good laugh out of it. He was trying to figure out in early MRs where the cancer was in prostate. We were looking at, he had the prostates up on the radiology image, and I had the microscope, and he's looking at the radiology and says, "Is this what prostate cancer looks like?" And I said, no, look over here at the microscope. This is what prostate cancer looks like. And then we started talking about how all of the image processing he was doing in radiology was exactly what we had to do in pathology. It was just we were going to add red, green, and blue and give him really, really sharp detail at, 0.2 of a micron. And I said, this whole field of computation on the glass, there's nobody competing with you right now. You could literally write the history of digital pathology. And we've been doing that ever since. It doesn't hurt that he enjoys Scotch as much as I do. So, so we have a lot of fun doing this. And, we get together. I drive out to Cleveland, once the pandemic's over, a couple of times a year, and we brainstorm and come up with new ideas, and then we go after grants on it. So it's been amazing.
Yeah, that's fantastic. Keeping it fresh with some Scotch and some new ideas. Well, what excites you? Where do you see the field headed in the next 10 years or so?
I think the idea of imaging tissue without making a slide is really interesting. So I think that's exciting. The idea that I practice breast pathology. So the idea that a woman could come in, have a biopsy, have it stained in a few seconds, and then have it imaged, and then have it read before she's gotten dressed to go home, I think is really compelling. So I think slideless imaging is really exciting. I think interrogating tissues in complex ways with RNA probes, antibody probes in high dimension is going to be really interesting as we try and figure out how to tweak the immune system to activate the immune system in select ways against tumors, which tumors are immune active, which are cool, and which are ice cold. So I think that's going to be interesting. I think microscopy, there's been some really exciting changes in microscopy that have won several Nobel Prizes. So I think being able to interrogate tissue at resolutions beyond light with multi-parametric stains is going to allow us to see more and more phenotype within the tissues. So you can begin to illuminate the epigenome that causes changes in the nuclear appearance that we see and we call pleomorphism and anaplasia. And so beginning to understand that and revealing it through spatial structure of the chromatin. I think there's some really interesting details in human disease at a super resolution that are going to become part of pathology. I think path and rads have really interesting non-overlapping modalities that can really inform patient outcomes. So I think integrated spaces are really cool and are going to become much more commonplace. So, those things excite me.
Yeah, well, it sounds like we have a lot to look forward to. Well, our guest has been Dr. Michael Feldman from University of Pennsylvania. We'll see you next time on Digital Pathology Today.